Hello. Let's briefly review blepharitis, hordeolum, and chalazion. So blepharitis is a inflammation of the eyelids, and it's one of the most frequently seen ocular diseases. It may be infectious or inflammatory in cause, but it's usually divided into two categories: anterior blepharitis versus posterior blepharitis. So the epidemiology is that anterior blepharitis affects the anterior lid margin and almost always caused by staphylococcal infection in young and middle-aged women, versus the seborrheic type in the older group of men and women in equal amounts of gender. Posterior blepharitis is located on the posterior lid, and for example, it examples Mobian gland dysfunction. It sometimes can be associated with rosacea, but either way, all forms may create dysfunction in ocular surface, exacerbate dry eyes, and result in hordeola or a stye or a chalazion. Pathophysiology of blepharitis is that anterior blepharitis is caused by abnormal cell-mediated response to Staphylococcus aureus versus anterior seborrheic blepharitis, which is associated with seborrhea, as we mentioned earlier. Persons may be predisposed, and we believe hormones play a role. Clinical presentation: the client will have complaint of burning, perhaps foreign body sensation, tearing, photophobia, itching, redness, discharge, and swollen erythematous eyelids, often worse in the morning. Hordeolums are painful, and chalazions do not cause pain. That's one way to differentiate. Physical exam: you want to include assessment of the face, ocular adnexa, and the eye. Staph causes lid erythema with fine ulceration. Seborrhea causes greasy scales along the lid margins. Both of those give you clues. All types of blepharitis may cause conjunctival injection, corneal infiltrates, excessive tearing, lid crusting, discharge, and lid margin inflammation. Diagnostically and the management and treatment: referral for biopsy may be required for chronic presentations and or to rule out any form of malignancy. Undoubtedly, lid hygiene is the mainstay of blepharitis treatment. You're trying to reduce the colonization of bacterium and remove the seborrhea. Artificial tears can be helpful for symptomatic relief. Antibiotics for Staphylococcus aureus can either be delivered topically and at times orally when you're dealing with the chronicity of it or the severity of it. And generally you'll see the tetracycline or doxycyclines being used. It just depends on the client. Anticipate chronic treatment. This is generally something that takes months to years to eliminate. Referrals, again, the ophthalmologist referral might be for chronicity or severity, but also biopsy may be required. Distinguishing styes and chalazions from basal cell carcinomas or other types of carcinomas imperative. As far as patient education, health promotion, daily eyelid hygiene and lid scrubs, and replacing eye makeup on a regular basis is important. Styes almost always resolve with a simplistic treatment versus chalazions, which persist and may need surgical removal. Thank you.